Top Bed Talk.
So welcome to the second Airway-related session of the afternoon entitled Teaching Airway Skills During and Beyond COVID-19. So my name is Janette Brohan. I'm an anesthesiologist and intensivist in Cork University Hospital in Ireland. And in addition to my involvement with the SIAA, I am co-chair of this meeting with Monty and Mike. So I'm delighted to chair this session. I would like to introduce the speaker of this highly relevant and topical session, who is a colleague of mine in Cork University Hospital, Dr. Niamh McAuliffe. Niamh, welcome to Virtual Dingle.
Thank you very much.
It's almost as much fun as real Dingle. Niamh, I might ask you to tell those tuning in about yourself and your background prior to hearing your presentation, if that's okay, and I'll touch base with you afterwards.
No problem. So my name is Niamh McAuliffe. I'm an anesthesiologist in Cork University Hospital. I've done fellowship training in Canada in cardiac and echocardiography and regional anaesthesia. I also had a teaching role in Toronto and fellowship coordinator there. So I brought some of that teaching experience back to Cork. My current role in Cork University Hospital is as a college tutor. So it's with this hat that I'm going to present on the challenges we faced when faced with NCHDs in this pandemic environment and the challenges of teaching novice anesthesiologists in July 2020. I'm going to talk a little bit about airway skills in 2020 and how they changed, and there'll be a little bit of repetition following on from Dr. Cook. How do we determine airway competency in our current education curriculum, and what our options are in airway education? So I think one of the best phrases from 2020 is do what you can with what you have where you are. And that certainly represents a lot of what we had to do in March of this year. It was the year where we discovered that being an anesthesiologist was sexy. And it was certainly the year when a large amount of our family members discovered what we actually did in our daily job for the first time. There were huge amounts of impediments to doing our day-to-day job, and plastic sprung up all over the place. And for advanced airway practitioners, there was a massive cognitive load and a massive stress related to this. Most of the people we were working with at the time were not novice airway practitioners, and we all struggled in achieving our day-to-day tasks. We discovered that having bag mask ventilated patients for years, we were now generating aerosols and had to have thoughts about how far a micron could travel across a room in an operating theatre. We were faced with wearing large amounts of PPE and certainly discovered that in emergency situations, our glasses fogged up, we couldn't hear our colleagues and we couldn't be heard in emergency situations. So all of our senses were dulled along with the massive cognitive load. You've heard the discussion about aerosol generating procedures and the degree of aerosol generating procedures related to what we do on a day-to-day basis prior to me starting. Certainly this paper, which was done with the prevalence of 1 in 200,000 of COVID-19 cases, gives us a framework when we're thinking about how we approach our NCHDs and our novice trainees. We still need to help the airway practitioner become an advanced airway practitioner, and our patients now come onto this category. So from this really nice study, for your risk of a COVID-19 encounter is about 1 in 10,000 with a prevalence of 1 in 200,000 when you're looking after a patient in the green pathway. So certainly how you teach trainees has to be educated by the risk of the encounter with each patient. Also we suddenly had to take into account not only the risk involved with teaching the trainee, but also all the other healthcare workers in the room and their stress and their perception of stress when we were teaching a trainee who was at risk of COVID-19. Bag mask ventilation. We consider this the core clinical skill in teaching any novice trainee in our department, and it suddenly became no longer an option. We've heard the discussion of video laryngoscopy, and overnight video laryngoscopy became the default technique for intubating for all practitioners throughout the hospitals. The sterile cockpit is something that has come from aviation. So along with a lot of the other safety mechanisms that we've taken from aviation, such as the surgical safety checklist and closed loop communication, Sylvain Boet et al. In Canada did a very nice study looking at the benefits for patient safety when we reduce all non-essential behaviours during critical moments of flight. And if you think of what we do now in terms of intubating patients, all personnel leave the room, usually apart from the anesthesiologists and their necessary assistants, and everyone stands outside the door in various degrees of PPE. This has advantages because now the intubation has become the focus and everyone is focused on intubation, and there's very little non-essential behaviour during intubation. as a result of COVID-19. And it certainly prioritised that. And there's no longer the cacophony of noise that can sometimes distract from what is an evolving critical situation. The disadvantages of this are significant for our trainees in that now when a trainee runs into difficulties or has unanticipated challenges, a lot of the necessary staff for help are no longer in the room. And it's certainly something to be cognizant of for our trainees who are operating at night, operating independently for the first time. When we look at our novice trainees, a massive amount of our training has now gone online in terms of simulation. So Maya Contreras in Galway and the Simulation Education Group in Galway did a huge amount of work in March and April of this year, training healthcare workers in application of PPE, minimising aerosol generation and crisis resource management. And a lot of our work was done training people in the simulation. It's a method of education which we're used to, and its use became very, very apparent when, for example, training tracheostomy patients with COVID-19 for the first time under plastic. This was done with low fidelity and high fidelity simulation, and certainly reduced the stress and anxiety for the trainees involved. The overall cognitive load of our jobs suddenly increased exponentially, and into this setting, in July 2020, when we just about figured out how to do our job, came the novice anaesthetist. So up until now, we had managed with advanced and beginners and advanced airway practitioners. The challenge of how to teach the novice for the first time was something that was hugely demanding. So these are people who presumably chose to do anaesthesia before the onset of the pandemic. And we are now faced with moving them along to advanced beginners without the ability to teach them how to do bag mask techniques on patients. A lot of how we teach our trainees in practice suddenly became difficult in terms of social distancing, and everything about how we taught our novices had to be reevaluated. There was huge amounts of innovation around the world and people teaching airway skills with packages posted out to homes from kitchen sinks using internet. And our resources ranged from the following. So didactic teaching we're well used to in terms of our internet skills, online resources. Low fidelity simulation teaching on airway mannequins is something we're also used to, but we're all used to being able to follow that up with real patient experience. And it's very, very difficult to teach some of the subtleties of bag mask ventilation on a low fidelity simulator or on a mannequin. PPE training, teaching NCHDs how to minimize their aerosol generation. And certainly the whole concept of how we train trainees comes into question. So most of us would have learned with an apprenticeship model. So learning airway skills from an advanced practitioner during patient care is the core of the apprenticeship model. The advantages are that it involves real anatomy. The physiology and pathology are presented with a wide range of presentations, and there's rapid procedural skill acquisition. The disadvantages of the apprenticeship model are that they are the least compatible with the goal of improved patient safety, and evaluation of potential optimization is not always done in a busy clinical setting. We have been moving from time-based to competency-based education in anaesthesia for quite some time now. But now that clinical opportunities and clinical learning opportunities are decreasing for NCHDs in the setting, competency-based education comes to the fore. So this is looking at learning objectives with measurable outcomes and looks at the result and the effect of training. We can no longer guarantee that putting an NCHD into 6 years of training will guarantee the degree of a clinical exposure that will result in a proficient practitioner at the end. And it certainly highlights the importance of competency-based medical education in our current time. But when we look at our core competency units and what we define as necessary for somebody to become functional and in basic airway competency skills, a lot of the things which we have taken for granted for now suddenly become challenging. So acquiring 30 bag mask ventilations, nasal intubations and fibre optic intubations become very difficult in training the NCHD and allowing them to progress to an advanced practitioner. Even for the advanced airway programs, teaching awake elective fibre optic intubations and high frequency jet ventilations are certainly going to be an issue going forward. So the competency-based medical education is based on adequate clinical exposure and timely workplace assessments. And there is concern about the lack of ability to do formative assessments. In Toronto this year, where they've been doing competency-based medical education for about 2 years, they look at the entrustable professional activity assessments, which are the core of the medical education curriculum, in the setting of a 65 to 80% decrease in the anaesthesia volumes. And interestingly enough, the amount of assessments completed during that time actually matched the amount relatively match the amount done last year, which I think says more for the drive and motivation of the residents involved to ensure that they get trained. One of the interesting concepts, which I think is something we need to consider going forward, is strategic pairing of residents and faculty to enable supervisor trainee entrustment in patient care related tasks. And that very simply makes sense. If you've worked with a trainee and you've seen them establish a task or you've seen them manage an area, you're much more likely to trust that trainee the following day to do something at a higher level. And I think we need to streamline our education and try and optimise the clinical education opportunities. And this is certainly something that we should consider in terms of mentorship and trying to ensure our trainees advance as quickly as possible. We did some feedback assessment for the trainees who started in July of this year, and when asked what their first line laryngoscopy tool was, they're all using the McGrath video laryngoscope in our hospital as a first line tool. However, they do have persistent anxiety, so they are all worried that they're not getting enough exposure to the Macintosh laryngoscope and then bag mask ventilation. Whether this is coming from our concern about this and whether they're picking up on it is hard to tell, but they all say that opportunities to create learning opportunities are harder to come by, and is certainly something we have to be aware of. As well as looking at the novice beginner and their acquisition of skills, we also have to look at the experts. So once you've been deemed clinically proficient by a time-based model, how do you maintain those skills in the current COVID environment? How do you maintain your skills in terms of advanced techniques and techniques that you don't use on a day-to-day basis? It is very important that we're not using airway exchange catheters or entry catheters for the first time in an emergency situation, and we need to maintain our skills. As advanced practitioners, we need to look beyond the operating room and we need to learn and assess our procedural skills. So we can look at simulation-based education for advanced practitioners becomes increasingly important. A focus on practice guidelines. Looking at mandatory airway training programs is certainly something to consider, and it's something they're doing in New Zealand and Australia. Training the trainer courses and teaching us how to train NCHDs in this environment is certainly something that's worth investing in. And considering auditing our airway practice as a lifelong practice is something we should all be doing going forward. Overall, we need to be aware that there are less opportunities to optimise our clinical skills, and regional anaesthesia has definitely come to the fore. Given that we can't see the situation changing in the short term, it's something we need to make the most of. And e-learning. So you may have come across this form of learning and simulation learning online in ACLS courses, but certainly the Veterans Affairs group in America have taken the difficult airway algorithm and rescue cricothyroidotomy online. So as well as didactic teaching, they've developed a game as a form of teaching, and it's certainly, I think, something our younger learners will be more familiar with. And the advent of, I think, online simulation as a form of learning in terms of airways is definitely something that is going to become more and more popular going forward. The last slide of the talk is beyond COVID-19, and it's certainly hard to see that beyond COVID-19 at the moment. There are certain aspects to the changes in our airway practice that I would definitely like to hold on to, but we need to be aware of our scale and to maximise all our learning opportunities, both for our novices and our advanced practitioners going forward. Thank you very much for listening.
So, yeah, thank you, Niamh, for that very engaging and thought-provoking talk. It clearly is of massive relevance to our specialty going forward, and how we teach our skill sets, how we actually impart knowledge and skill sets to those that we're tutoring. I would like to welcome our panel members. Monty, of course, you already know, but could I actually ask the other panel members, who are all most welcome, to introduce yourselves?
Hi, yeah, it's Brian O'Brien here. I'm an anaesthetist and intensive care doctor in Cork University Hospital. I'm also heavily involved with, I guess, in Cork alone, there's a lot of training that I've been involved with, and I'm chairman of training at the College of Anaesthetists in Dublin as well. So those roles kind of give me a big interest in the Top Gunner discussion today, and well done to everybody on a clear presentation so far. Thanks.
Hi, Ray O'Connor, another consultant anaesthetist in Cork.
I will ask for kind of whip around the panel for your initial thoughts on the topic after Niamh's presentation, or questions you have for Niamh yourselves. But before we get to that, I guess the question that comes to my mind first off, Niamh, is what's the solution? How do we impart the skill set in the current environment, given that it probably will go on for an awful long time?
I know I was hesitant in putting up a slide with the solution on it, because it's really quite difficult in terms, I mean, we can use all the resources that we have already, But a lot of it comes down to ultimately our own perception of risk and the NCHD or the trainees' perception of risk. And I think we have to consider it largely on a case-by-case basis and consider the individual needs of the learners as opposed to just blanketing them all together. And I think we have to be more focused on their individual learning needs and more in tune to them, and count less on that time-based model that we're also used to.
Patients come in all sorts of different shapes and sizes and anatomical variations and positioning issues and whatever it is. So for a lot of things you might read, simulation is posed as the answer, but I don't know what your thoughts on it. My thoughts are simulation models don't quite emulate the variety of shapes, of sizes and conditions that our patients are in when it comes to airway management.
I think teaching airway management is one of the things done most poorly by simulation, because there's a lot of the other crisis resource management stuff and the intercommunication and technical skills that are done well in the simulator. I have yet to come across a simulation format that will simulate holding onto a large airway until your knuckles are white with that degree of stress, and explaining that to an NCHD. So I think also, as we are trying to get our simulation courses up and running now for the coming winter, we're really struggling with logistics, numbers of people that you can have in a simulator, what constitutes close contacts, the stress levels involved, and just actually running our normal simulation courses. And certainly, I think, despite our best efforts, when you talk to the trainees who started in July, while they found the low fidelity simulations that we tried to do before they started helpful, it certainly was no substitute for learning on patients. And when I go through their numbers, many of them have actually achieved 30 bag mask ventilations, which just about makes their core competency in terms of a novice to a more advanced airway practitioner. But they're certainly going to miss out in terms of the airway numbers that I would have matched at the same level.
I believe Vicky is back with us. Apologies about that. Do you want to introduce yourself
Yes.
to the rest of the panel?
Yeah, Viki Mitchell. I'm a consultant anaesthetist at University College Hospital, and I've got a long-standing interest in airway management, and I'm the clinical director of the department, so I'm responsible for everyone being able to intubate or not.
So Vicky, where do you think this is going in terms of our ability to impart our knowledge base, less knowledge base, that can be book learned or online learned, but it's more the physical skill set of holding this difficult airway, as Niamh just alluded to, or the difficult laryngoscopy that's unanticipated, for example, being able to teach that?
Well, one thing that I think has been really interesting in the whole COVID crisis is adopting an SOP for intubation. So that whole task load thing, that's really helped, I think. We largely protected our trainees, though, because we had it was always our most senior person would intubate. I think Tim Cook made a really good point about the benefit. You don't really realise the benefits of video laryngoscopy until you start using it. We had an airway deaf, actually, so we moved to video laryngoscopes everywhere. That's how we got the funding. And we've got the glide scope, which actually doesn't have a very good Macintosh blade, but it's still brilliant for teaching novices because you can actually see what they're doing. And I hadn't really appreciated that until we got the device. I thought the thing to do would be to teach them direct laryngoscopy using a Macintosh laryngoscope whilst the trainer looked at the screen, and then let them progress to to video laryngoscopy once they've mastered that skill. But now I think it's the other way around. You can teach much more effectively. You can show them the anatomy. You can see the nuances of their technique, how to direct a bougie using a video laryngoscope. So I've completely changed my position on that. And I think it's been a real advantage for teaching this technical skill. So the other thing that I've noticed is that mannequins are quite hard to intubate compared to human beings. Yeah. So sim creates a more artificially difficult environment. So it's always better on a human.
The difficulty with now Tim Cook may see nothing wrong with this, but the difficulty with us, the issue with us leaning on video laryngoscopy more and more now in terms of teaching and what we actually do day to day in terms of airway management, is you can have the situation that I had about a month ago where I was working in theatre with a second year anaesthesia trainee who told me that he had never used direct laryngoscopy before. And that was his second year in training. So that's the trade-off, I guess, whilst there clearly is a massive advantage, as you said, to video laryngoscopy. Can I bring Brian in here and ask, just in terms of the college and the college training pathways, or I presume the college has discussed these issues, and where do you think that will go?
Yeah, thank you, Jan. In terms of kind of official college position, we're still really at quite an early stage, because you'll appreciate that, the new contingent of doctors only started in July, so we're only a few months on from that. And having any kind of central meetings hasn't really been possible. So, even I, who normally am in the college every second week, haven't been there in months now. So there is a bit of a frustration with the communication to any kind of formalized central database of the feedback from trainees. But to go back a bit from that, and I will return to that point in a moment, but I started out really looking at this process of using video laryngoscopes analogous to what Monty was saying. That is to say, I can remember when I was being sent to put lines into people with HIV infection, and nobody particularly thought about my risk of, catching anything from that, and it just seemed to be a part of life. And in some ways, one can kind of think, well, I went through it, and therefore, that's the kind of baptism of fire. But in fact, we do seem to just have evolved into far more sophisticated times, and to be living in a better environment, really, for people to learn. Now, given all of that, we also tend to be rather emotionally attached to skills and knowledge that really we struggled hard or worked hard to acquire. And learning how to use a Macintosh is an example of that I think we all feel that it should be a core skill. As you were saying, or analogous to what you were saying, Jan, a few days ago I was in theatre with a trainee anaesthetist, and I suggested that she, just for the purpose of experience, intubate with a bougie. And I handed her a Macintosh laryngoscope, and she said she didn't realize you could use a bougie with a Macintosh laryngoscope. And I kind of explained all that actually was what it was originally for. But she is only in the job a short time, and tends to think that bougies go with McGrath laryngoscopes, and that's the obvious combination. So another useful comparison made earlier this morning, I think, in conversation between Alistair and Monty, was that it's a bit like using ultrasound central lines, that when you get used to it, or if you grow up with it, it becomes intuitive. But retro learning or retrofitting it into your brain can be a slight challenge in its own way. And I think a lot of us have kind of worked backwards to kind of force ourselves to use, newer devices, and then gradually come to fully appreciate the benefits of it. Now, to come at this from the kind of college angle then, as a chairman of training, I had serious misgivings about the PPE environment that we were bringing new trainees into. I really thought they would dislike it intensely. I thought it would put them off anaesthetics as a career. And we work so hard to recruit good people, and it takes such a long time, that I was terrified that a lot of them would, after a few months, say, look, this is useless, and look for a better job. Very much to my surprise, at our preliminary assessments 2 or 3 months after the new group started, so we had about 44, to be precise, 44 new trainees started the SAT program in July. But actually the feedback is very strongly positive at all levels. I find this very interesting that, those of us who've been doing anaesthetics for years are actually rather exasperated by having to wear PPE. But to look at it from a 180-degree point of view, for the new trainees, they've actually entered anaesthesia or chosen anaesthesia as a profession when it was perceived as very obscure, low-key. And oddly enough, it's kind of been making front-page headlines in the newspapers while they've been starting into it. And, there is a sense, perhaps, in which they suddenly feel part of a team that you could say at least is being appreciated for its importance. Whereas, we used to do jobs that if we mentioned to somebody socially what we did for a living, they would immediately change the topic. So it actually has been extremely popular with beginners, and they are actually, conversely to what we find, they find it much easier then to learn to use the old-fashioned equipment without, necessarily having to wear PPE. I'm hoping sometime we'll go back to that level. So I think it is ultimately, as I would see it, the kind of way of the future. I think there is a great deal of merit in young trainees learning how to use the older-fashioned equipment, and right down to bag mask ventilation. I think a lot of reassurance can be taken from some of the recent studies on aerosolization during bag mask ventilation. And I think, like in many things in anaesthesia, it probably will turn out that we have in fact been overcautious in the midst of this pandemic. We'll probably only know that in a few years' time. But I think so far what we have seen is actually very high levels of occupational protection of people, with occasional cases of actual COVID arising. But it hasn't been as big a problem as one might have expected some months ago, given the the R number of 4 and the number of patients that we've encountered. So looking at all of this, I think for us older anaesthetists, we're probably going to have to, for much of our career, adapt to using video laryngoscopes, lots of protective equipment, and to find creative ways to teach, which will obviously involve simulation and so forth. But I think it is actually far less of a deterrent to younger trainees than I had feared. And I'm in many ways thankful that they're growing up in a more protected environment than I did. In many ways, it's kind of surprising that a lot of us got through it at all.
You haven't seen numbers falling off in terms of those interested in the specialty anyhow, which is encouraging.
Could I just say in conclusion, Jan, well done to you and well done to Monty in keeping the Dingle show on the road. It's a really important thing. It's a crucial link between Ireland and the UK in the kind of anaesthetic and intensive care communities, and particularly, following Siobhan's death a few years ago. I think it's so important that we keep it going. So well done to all involved, and thank you for that.
I completely agree. We're not in Dingle, unfortunately, which is the limitation of this year, but next year, hopefully.
Nonetheless, the show goes on. So.
I might bring Ray into this because, Ray, you work an awful lot with the extreme level of young pediatrics, like difficult airways. You do a lot of cleft palate surgery and that. So in your neck of the woods and in your specialties, how do you envisage, I guess you take a lot of care with your airways and probably impart that skill set very carefully to those that you're training. And how going to change going forward?
Yeah, I mean, with regards to pediatrics in particular, it's a little bit of a different situation in that with the majority of adults, for example, the kind of standard technique we've been having of a good long pre-oxygenation using rocuronium and then not bagging them. Unfortunately, with a lot of the small kids, they will desaturate pretty rapidly. So even with that, we've been trying to figure out ways of obviously trying to make sure everyone's COVID negative, obviously beforehand, but it's very difficult to not do any form of hand ventilation with the very small children before you have muscle relaxant work. I think going forward, video laryngoscopes are going to be the way to go with very small kids as well. In particular with the smaller kids, before their epiglottis becomes more of an adult shape and you need a straight bladed laryngoscope, things like a CMAC are particularly useful. And like that with adults, it just allows everybody else in the room to actually see what's going on. I always think with airways, there's kind of, broadly speaking, very broadly speaking, 3 types of difficult airway. You can have an anatomically difficult one, which is the ones we deal with in theatre on a pretty regular basis. A situationally difficult one, where you don't know who's around you, what people are doing, you're in a strange place, like you're down a recess intubating someone. And a physiologically difficult one, where there's other factors apart from the airway, like somebody with cardiovascular instability or C-spine instability, etc., that you're also trying to manage. And I think in particular with COVID, with the amount of PPE that we have, we've taken what is usually a situationally okay airway inside in every theatre and made it nearly a situationally difficult situation. Our communication isn't there. Our masks are fogging up, like you've said. People are getting, you've been wearing PPE for a long time. It's digging into you. You're distracted by it. And automatically a video laryngoscope reduces some of the anatomical uncertainty. So everyone can see what's going on there. You reduce the amount of kind of non-verbal communication that's required. People can see that you're going to need a bougie. They can see you might need a little bit of burp, etc. So I think it's made a huge difference from that point of view and probably precipitated what was going to happen down the line anyway. I've always thought that things like the McGrath should be the go-to laryngoscope if you're ever down in resus intubating someone, just because it always makes it much easier for everyone around you to see what's going on. And I think with anaesthetic practice, COVID has just precipitated that change that was probably going to happen down the line anyway. So I think it's no harm. One other thing I do worry about to some extent is when we limit the amount of practice people get with things like hand ventilation or using routine laryngoscopes. I think we're kind of changing people's habits for how they manage airways. Basically, since the practice or since the speciality began, the default is that you hand ventilate someone. Whereas now, trainees nearly need permission to hand ventilate someone. You can see them, they look at you and kind of, you kind of have to say, it's okay, go on, hand ventilate them, or try and hand ventilate them. So I think we've removed nearly a subconscious habit out of people that is one of the default step backs when we're having trouble with an airway, to just hand ventilate them, let everything settle down and give yourself time to think. But I think we've nearly removed that kind of ingrained habit to some extent from trainees going forward.
That's a fear I have also. Niamh, have you any words of wisdom about how we can solve that problem?
I think I could take it back to that risk algorithm, because there's some things we just need to teach and we just need to do. So I think the only way to bag mask somebody is to bag mask somebody, and we can't just be blanket afraid to let our NCHDs bag mask patients. As Ray said, we have to promote an awareness of the risk and not to be blindly afraid to bag mask somebody if they're going to desaturate. So, for example, someone on a green pathway who's been COVID negative swabbed, who's at low risk, these are the patients that we should be encouraging our NCHDs to bag and to learn all those clinical skills, so that we do have the safe airway practitioner when we get to the other end. And I think it's our responsibility to take that on board and to manage their fear and their anxiety and to guide them through so that they end up being the complete airway practitioner we know that they need to be. Because I would certainly agree with Ray, there will come a scenario when someone desaturates clinically and becomes unstable because everyone was afraid to bag mask a patient, and that's a kind of a horrifying scenario.
Monty, are there any questions or thoughts from the studio there, or do you want to divert to Slido questions?
I think, Jan, in the interest of time, we should take the Slido question here, because it refers to the medical student. So I've been challenged by the presence of undergraduate medical students in theatre, and I'm assuming this is in the context of what's going on at the moment. Should they be there is one question, and what should they be shown, and what should I let them do?
I suppose I'll answer that first, because that is a subject that has provoked much discussion at an undergraduate level, and it is very, very contentious. And currently, our medical students are not in theatre when we intubate, and it is something that have to be reviewed on an ongoing basis. But that is what happens. We teach them, we talk them through it, we do all the didactic education. But at the point of intubation, they are asked to leave, and they're not allowed back in until the airway is secured. And that is currently our situation. And frankly, it's something I'm happy with. While I understand they need to learn, I think we're more comfortable prioritizing our anaesthetic trainees for the moment. And while we don't really know what goes on in terms of aerosol generation in the operating theatres, it's certainly where I'm more comfortable at the present time.
Jan, can I also give you a quick update on the poll?
Yes, please.
Okay, so we're up to 246 votes now. So if anyone wants to ring around their friends and tell them to join in quickly before the meeting finishes. But on the question of, is video laryngoscopy now first choice stroke standard of care, we have 6% not sure, 45% no, and now we have not sure it's a clear leader. I'm not sure that's statistically significant, but it's a win. First across the line at the moment is yes, with 49%. I don't know if we're going to do first past the post, or if we're going to have a 2/3 majority, or whatever it is, or if this makes any difference at all. But at the moment, VL is winning. College electorate.
Let's go college electorate.
we could have a single transferable vote to from yes to not sure, maybe. Okay, Jan, if it's okay, because in the interest of time, could I ask you to wrap the session and say thank you to everyone?
I think we need to wrap this up. So thank you to Niamh for a fantastic presentation and a very provocative discussion, which we could, I think, drag on for another hour or two if we had the opportunity. It is unfortunate that we aren't all in Dingle in person. I do hope that you'll all come back to us in Dingle and join the Dingle family again next year, where hopefully we will be there in person with all of the socialising aspects that the Dingle conference is known for. So thank you very much to Niamh and to all the panellists, and to Monty and to Mike.
Thank you all. Take care.
Bye.
Thank you very much.
Thank you.
See you soon for our final plenary.
Top Med Talk. Thanks for listening to Top Med Talk. We are excited to announce the World Congress of Perioperative Medicine happening in London this year. Check it out at ebpom.org. It will take you through to our carbon-free conference center, where it has the EBPOM platform. You can find more information. Be sure to subscribe to Top Med Talk and EBPOM at ebpom.org.